Hello guys, I am Deepak Shukla. Welcome to our channel Study Mania. Today let's learn about CSF rhinorrhea. If CSF is present as nasal discharge, we call it as CSF rhinorrhea. Okay. So if there is break in the skull bone base or breach in the dura or meninges, the CSF may leak out from nose. That is called CSF rhinorrhea. Which is the most common site? The most common site is the weakest bone, that is cribriform plate. And the most common cause is traumatic usually. It can be direct trauma or post-surgical, that is iatrogenic. What are the non-traumatic cause? Non-traumatic cause is high pressure leak. It may be tumor or BIH that causes increased intracranial pressure. What is BIH? It is benign intracranial hypertension that is seen in fertile 40 females. Okay. There can be cases where the pressure is normal, but then to CSF rhinorrhea may be present. Those are congenital pathway defects, defects in skull bone base, that is empty sella syndrome, erosion of bone from below, that is NPC, JNA, and osteomyelitis. So these are the causes where CSF rhinorrhea can be seen. What are the clinical features? Clinical features are watery nasal discharge, and is usually unilateral and increases on bending forward. Okay, very important, increases on bending forward. So how to differentiate CSF rhinorrhea from simple rhinorrhea? Okay, so there are some simple tests. First one is sniff test. Nasal fluid can be sniffed back. Okay, if we'll like sniff back nasal fluids in rhinitis or allergic rhinitis, sinusitis, it can be sniffed back, but CSF cannot be sniffed back. Very important. Second one is halo sign or target sign or double ring sign. Okay, here you will see peripheral halo. In central red will be there, then halo will be there, and then again redness will be there. That is called target sign. It is suggestive of traumatic CSF rhinorrhea. Coming to reservoir sign, I have already said that discharge increases on bending forward. So here we have reservoir sign or teapot sign. Okay, teapot sign, like here something teapot sign. So suppose this is CSF from the brain and it increases, like more secretion will be there from nose on bending. Okay, so in supine position there is collection of CSF in the nasal cavities and paranasal sinuses. Okay, nasal cavity and paranasal sinuses. Patient propped up and asked to bend forward, there is flow of CSF. That is called reservoir sign or teapot sign. Then we have handkerchief test. There is no stiffening of handkerchief in CSF rhinorrhea. Actually, when in allergic rhinitis or normal rhinorrhea, the handkerchief will become sticky. But here in case of CSF rhinorrhea, it is not so. Glucose estimation of fluid. Okay, glucose in CSF is 2/3 of blood glucose, that is 60 to 80 mg per deciliter. Now coming to the important test, that is beta 2 transferrin test. It is present only in CSF. Therefore, the diagnostic test for CSF rhinorrhea is beta 2 transferrin test. Exception is aqueous humor and perilymph. That is ultrafiltrates will not find these. And then beta trace proteins. Okay, beta 2 transferrin protein and beta trace proteins. These are the tests for CSF. Coming to radiological investigation, we have HRCT. HRCT is the investigation of choice, the diagnostic test for knowing the site of lesion. Okay, and something is called CT cysternography. If there is multiple sites, to know the active site of leakage, we'll do CT cysternography. So here what we do, we have to do a lumbar puncture, we have to obtain CSF. Now mix this CSF with 5% fluorescein dye. Okay, 5% fluorescein dye, and then re-inject. The dye will stain whole brain and spinal cord. Okay, the dye will stain whole brain and spinal cord, and dye will automatically come out from the active site. Okay, if suppose this is the active site and if we are injecting it back, the dye will come out from this site automatically. Okay, so we can find out the active site of leakage. Okay, but it will not come from these sites. To find the active leaking site, we will do CT cysternography. MRI is done to know the intracranial abnormality, if any tumor or something is there. What is the treatment? Initially, conservative treatment is done. Usually, endoscopic endonasal approach to repair the leak. or we can say transnasal endoscopy approach. Rarely we'll do transcranial approach, and it depends upon the site of the lesion. What we need to do, if there is any defect, we have to fill it with a graft. The graft can be either fat, facial lata, concave cartilage, septal cartilage, etc. And we have to just fill the defect with the graft. And it depends upon the type of the leakage. Okay. So one of the most important facial fracture with complaints of CSF is rhinorrhea is class 3 nasal fracture and Leaford 3 fracture. We'll learn in different type of facial fractures. Okay. So this was about the CSF rhinorrhea. So what is that? What is the main cause? What is the clinical features? How to differentiate? What is the diagnostic test, that is beta 2 transferrin protein? What is the radiological investigation? What is CT cysternography? And then what is the transnasal endoscopy, transcranial approach, and how to treat? What are the grafts that you use? Okay. Thank you.